Thank you very much for the kind invitation. I feel very honored to be present in One Health and Biosafety. I have been in India 6 times, and it has been an extraordinary experience. They have kindly honored me several times. So I have a heart for India in my talks, as you will see. So I want to show you life at high altitude and its impact on infections and the importance of what we learn here at high altitude as specialists in high altitude medicine. I want to first show you these images that are exactly the city of La Paz in South America. You see there the cable cars, and you can see the skyscrapers. These cable cars are like a metro because in the mountains it's very difficult to build a metro because the city goes from 4,100 meters to 3,100 meters. And that on the background is the mountain Illimani. You see the people running around, living a perfectly normal life, and with a population of 2 million every day. So the question is, my talk is termed Chronic Hypoxia, a remarkable stimulus for enhanced survival in infectious diseases, including COVID-19. And it is here that I want to show you where Bolivia is located. As you can see, the location is in the center of South America, and you can see here that it's part of the world in the highlands, but also in the Amazon. You see the ranges in altitude. It is a city that is absolutely beautiful, one of the 7 marvels in the world. And it is quite amazing. You have to come visit us to see all this wonderful city and its environment. Here's a night view. So when you are at sea level, the PaO2 is around 98 millimeters of mercury, and the PaCO2 40 and hematocrit 42%. When you come to the city of La Paz, you arrive in a flight at this altitude, and you arrive at the airport at 4,100 meters at the top of the city, and then go down in this city. And when you arrive, if we measure your blood gases, we will all see that the PaO2 has dropped to 60 and the PaCO2 to 30. If you come up very fast and you move around the first day, you can have acute mountain sickness, HAPE or HAZE, high altitude pulmonary edema or high altitude cerebral edema. But if you come up slowly, then you're really, what happens here is that you will have a perfect adaptation to high altitude, and your hematocrit will rise to 50%, and chronic hypoxia will not be bad for you. It will actually be very good for you and your survival. At the beginning of the pandemic, in January 31st, 2020, I was asked to participate in a radio interview regarding COVID. But this was too early. COVID had not arrived to Bolivia, so I didn't have much knowledge as anyone here, but except what we read. But there I affirmed that I made the first hypothesis that COVID-19 would be less severe at high altitude for several reasons, among them higher ultraviolet radiation, many aspects of tolerance to hypoxia, and so on. So this is why I talk in this important conference about COVID-19 and high altitude. When the doctors saw these lesions in the lung, these immense lesions, and people started dying, it was indeed very alarming, very, very alarming. You see the way the lesions grow there. It is absolutely worrisome. And so they immediately said, it's pneumonia, SARS pneumonia. We need ventilators. But the reality is that at sea level, the hypoxia levels that alarm physicians during lung compromise and COVID, along with tachypnea, is a saturation of less than 90%, and they went into ventilator use. Whereas in the city of La Paz, our normal saturation is 90%, with a PaO2 of 60 millimeters, and this is perfectly normal. There are some of our publications for those of you that are interested. In COVID patients, what is the efficiency of the use of ventilators in intensive care units? In New York, 88% of the patients on ventilation lost their lives. Why? Because it was considered a pneumonia, and they ventilated these patients as if it was a regular pneumonia. This was a big mistake. A new terminology was introduced by us called pneumolysis. Pneumo stands for lung. Lysis means destruction, the destruction of the lung. The virus goes into the alveoli and destroys them, destruction of the alveolar capillary tissue. So these are the differences between pneumonia or pneumonitis and pneumolysis. I am short of time to give you all the details, but as you can see, this is like a typical pneumonia where you see the lung related aspect of the pneumonia, and this is a pneumolysis where there is compromise of many areas of the lung and of course very severe alterations. This is the oxygen transport triad in COVID that we have described, the pneumodynamic pump and the hemodynamic pump, and you can see here that there's respiratory rate, heart rate, tidal volume, and systolic volume. These are all limited from two different pumps. One's an air pump and the other one's a blood pump, which are the lungs and the heart. And the hemoglobin plays a fundamental role. So you see here we have in COVID lung destruction called pneumolysis, where the lung is reduced in volume because of the compromise of the alveoli, of course, as you all understand. And the arterial saturation of oxygen drops, the PaO2 drops, and eventually the carbon dioxide PaCO2 is elevated. And so this gives rise to gasping and terrible conditions and death, of course. So we can see here that the heart rate, the respiratory rate increases, tidal volume increases alarmingly, heart rate increases, the stroke volume increases, but there's already an inefficiency of the system. And so we have to understand that COVID puts you on the summit of Mount Everest in a matter of days. You see, the highest point tolerable in extreme hypoxia, where life is possible, if you go up slowly to the Mount Everest. People have gone, Messner and Habeler have reached the summit, and many others now, with no oxygen, the summit of Mount Everest. But that takes a long time of adaptation, months of adaptation and increase of red blood cells. So in COVID, it was a sudden increase with insufficient hemoglobin, an excessive increase of arterial carbon dioxide, creating critical hypoxia, and of course, the end of life. So what is the difference between high altitude pulmonary edema and pneumolysis in COVID-19? This is, for instance, a chest x-rays, a CAT scan actually, of a high altitude pulmonary edema. Look at the arterial oxygen tension, 34 millimeters of mercury, and SpO2 of 53%. The chest x-rays in high altitude pulmonary edema with a PaO2 of 30 millimeters of mercury, but in 24 or up to 48 hours in a young person, you can see the lungs clearing and the values of PaO2 returning to normal high altitude values of PaO2 of 60 and normal at 3,500 meters. Whereas in COVID, there is an evolution in lung compromise, a serious evolution, where the lungs start to be more and more compromised fast in a matter of a week or so. And of course, with the invasion of the virus going into the alveoli, you see the viruses all over the alveolar areas. And what happens there is that this virus, this COVID virus, enters through the ACE2 receptors, and it enters the cells. And so it starts reproducing within the alveoli, and you can understand that this reduces the transport of oxygen gradually. And once the alveoli is full of the reproduction of the COVID, the virus, then it starts going out of that and going into different parts of the lung. That's why it is so extensively distributed. And of course, it compromises, of course, the also circulation. So this pneumolysis is lung destruction. It's something different from pneumonia. Unfortunately, it isn't quite well understood up to now, and it will eventually. There's an histopathology with Mason's body, things that we have seen in some of our papers, published here with some colleagues from Mexico, and fibrinous tissue and so on. I don't have time to give you many details, but this is my father, who passed away in 2015, and he affirmed that the organic systems of human beings and all other species tend towards adaptation to any environmental change within an optimal period of time, and never tends toward regression that inevitably leads to death. Now, as you can see, the concept of pneumolysis is a very important concept that needs to be understood. It will take time for it to be understood, of course, but life, for instance, at high altitude shows us that we have extended longevity at high altitude. It's one of the benefits of exposure to chronic hypoxia. You see, as we go up in altitude in the different cities of Bolivia, we have longer lives. The higher we live, we have longer lives. And this is a part of the adaptation to chronic hypoxia. We have done many studies, among them COVID-19 in 5 countries in South America. And in all of them, we found higher case fatality rate in all the highlands. I mean, in all the lowlands as compared to the highlands, where it was actually lower. These are many of the publications that we have done. The Andean condor, as you know, is a very beautiful bird, and we have symbolically used his vision that is very acute to look at COVID from the high altitude point of view. And these are some of the publications where we are talking about pneumolysis at the beginning of the pandemic, and pneumolysis and silent hypoxemia. And what happens here, if you see the red line, the oxygen tension that was normal at sea level of 100 starts gradually going down as the pneumolysis increases, but the ventilation remains relatively unchanged. This was the area called silent hypoxemia. But once the CO2 cannot be ventilated, as you know, it's 20 times more easily diffusible than oxygen, then at a certain point, the lungs are so compromised that it starts increasing, and of course the pH drops, and there's the gasping area, and it becomes a deadly event. So these lesions increase tremendously in the lung and aggravate the condition. So we live with a PaO2 of 60 millimeters of chronic hypoxia. I have lived 68 years, my father 90 years at high altitude with these levels, and we are quite healthy. This is called normoxia for us. And here is our hyperoxia when we go down. And the tolerance to hypoxia at high altitude is, of course, very interesting, because at sea level you cannot tolerate low oxygen levels, whereas at high altitude we tolerate it very well. This grants us capacity for survival. This is the distribution of arterial carbon dioxide in 1,865 patients at our institute, and you will see that at sea level the PaCO2 is 40 where you are located, but in La Paz it's 30 millimeters of mercury. And this is a graph showing the PaCO2 going up in altitude, and you can see that starts at 40, going back in La Paz 30, and all the way to Mount Everest where it's around 80. But in COVID, it's the other way around. COVID produces an increase of carbon dioxide. That's why it's so lethal. And this is the hemoglobin. And hemoglobin goes up as we go up in altitude. You see how it's going up in altitude. But COVID has low oxygen levels and low hemoglobin levels, and of course, less tolerance to hypoxia, which is lethal. This is our tolerance to hypoxia formula that has hemoglobin divided by PaCO2. I cannot give you further details due to the lack of time. And this is a very important aspect of understanding COVID. So we wrote several articles like this one, Coping with Hypoxemia. Could erythropoietin EPO be an adjunctant of in the treatment of COVID-19? We have shown that it was fair. I have treated many patients with EPO, erythropoietin, and I have had a great success of treatment with these patients. As you know, terraforming is going to happen. That's Mars. And so terraforming is a term that's used in the United States. They want to change this to become like Earth. Now that's very difficult. But they had overlooked one aspect, and that's what I called biospace forming. This is the adaptation of the humans, and that's very important to understand, because humans, animals, and plants have to also adapt to space, and also in the colonies where man will evolve. So the first step of adaptation is indeed chronic hypoxia. That's the first step of biospace forming. Now I want to show you what happens when we have proposed from several years now that in order to go to space, humans should be learning to deal with chronic hypoxia, because this would reduce the amount of pressure changes in spaceships from 510 to go from the spaceship to put on a spacesuit, whereas in being exposed to chronic hypoxia, that's why we propose chronic hypoxia should go to space, because the advantages are that the biology can truly play a significant role starting with a higher starting pressure, and it will go over physics to improve things. And so I'm almost finished here at the University of Copenhagen with Professor Paul-Erik Pauleb and Ole Sigurd Andersen, the famous Ole Sigurd Andersen for acid base, where we have worked and created modified tables. This is our hyperoxic hypoxic adaptation chamber. This is our Chacaltaya Pyramid Laboratory at 5,250 meters, just 2 hours from La Paz. And this is my father, the mountain guru, Professor Dr. Gustavo Zubieta Castillo, named at St. John's University in Bangalore, thanks to Professor Venkatesh. And here we are, the 3 generations, the year that my father passed away. That's my daughter, Natalia, on the right. She's an MD doing a PhD at the University of Calgary. Here's one of the visits at Era University in Lucknow. And here is the Agra Hospital. You can see Professor Venkatesh and our friend Shashi. And here is at King George's University. We're lighting the candles of wisdom. And this is where they named me the Hypoxia Man. This is the formula of adaptation to high altitude. And this is the highest mountain in Bolivia at 6,542 meters, where we carried out a soccer game. We were told we shouldn't do that because that's too high, somebody could die. But you can see here the guides and porters playing a soccer game 2-2. They tied. They played 20 minutes per side successfully. Obviously, nobody died because they are adapted to chronic hypoxia. And this is the proof that humans, when they adapt to chronic hypoxia, have great advantages. And this way, we finish our talk and continue with an invitation to you to join us at the World Capital of Hypoxia on February 24th to March the 1st, 2025 next year, where we will have our 9th Chronic Hypoxia Symposium and the first High-Altitude Space Physiology Symposia. The first High-Altitude Space Physiology Symposia of great interest. This will be chaired by Alan Hargens, is a great NASA scientist, and several others will be also attending. Please join us to have a unique experience of exposure to chronic hypoxia. I want to thank Natalia Zubieta de Urioste, my daughter, Lucrecia de Urioste Limariño, my wife, my other great collaborators, Rafaela Zubieta de Urioste, Lucia Gisbert, and all the people that I work with. Thank you very much.